This is a case of chronic tonsillitis in a 16-year-old female, and we have planned coblation tonsillectomy for her. I will be using an EVAC 70 plasma wand by Smith& Nephew at a setting of 7 for ablation and 3 for coagulation. As you can see, I have retracted the anterior pillar and got hold of tonsillar tissue with the help of an Ellis forceps. Now I will pull the tonsil medially and will look for the lateral most boundary of the tonsil. I will start my mucosal incision with the help of the wand. I will take the incision just lateral to the anterior pillar or at the anterior pillar so that I can find my correct plane easily. The plane will be completely avascular and therefore it will make our surgery bloodless. We have to apply a good traction and counter traction by pulling the tonsil medially. By pulling the tonsil, our plane will become more evident and it will be easily seen. Do a little bit of coagulation of the small vessels along the way so that they do not bleed. As you can see, I have found my correct plane and now I will open my plane like a book. I will do a equal dissection from all the sides. I will not create a tunnel by doing a dissection at only one place as it will increase the risk of bleeding and other complications. You can easily see the wide fibers of connective tissue which are connecting the tonsillar tissue with the tonsillar bed. We have to divide at the junction of the tonsil tissue and the fibrous tissue so that we don't open up the muscles. The patient will get a post-operative pain if we expose the muscles. By exposing the muscles, it will lead to myositis and which will eventually lead to pain in the post-operative period. So to make it a painless surgery, we have to maintain the fascia over the muscles and we don't have to expose the muscles. We can dissect at the junction of the connective tissue and the tonsil so that we prevent this opening up of the fascia. Till now, you can see our dissection field is completely bloodless. It is because we found out the correct plane at the start of the surgery. A good plane will make this surgery completely bloodless. There will not be any single drop of blood. Keep changing the grip of the tonsil so that you give a good traction. A good traction help us to see the connective tissue fibers more clearly. We can clearly see the complete tonsillar bed till now is covered with the fibrous tissue or the fascia and no muscle is exposed. The tonsillar tissue is more firmly adherent at the lower pore of the tonsil. This is the point where tonsil will be more firmly adherent to the tonsillar bed. So we have to do a little bit of more dissection here to make the tonsil free of the bed. And we are opening the tonsil like a book. This is the place of the tonsillar artery. We will do a prophylactic coagulation along the path of the tonsillar artery so that we don't accidentally open up the artery. A little bit of the bleeding from the tonsillar tissue which can be easily coagulated. I can see a paratonsillar vein and I have coagulated the vein along its path. Paratonsillar vein will be present in peritonsillar space. You can see I have dissected the tonsillar tissue from the bed. We can clearly make out the tonsillar tissue from the connective tissue. If you are able to make the differentiation, then your tonsil surgery will be very easy. You just have to differentiate the tonsil tissue from the fibrous tissue, and you have to divide at the junction of them. Now I am trying to free the tonsil from the upper pole. Try not to damage the uvula during the dissection, as the uvula can get pulled in the wand due to the pressure of the suction. Use the wand very carefully. The speed of the wand should be optimum. It should not be too fast or too slow. If you are moving your hand too fast, then the wand will not coagulate the small vessels along the way and it will lead to bleeding. And if you are moving your wand too slow, it will lead to the charring of the tissue. So, optimal irrigation and the movement of the wand is very important for a good surgery. Now, the tonsillectomy is almost complete. You can see the complete tonsillar tissue dissected from the bed. This is how a tonsillectomy should look like. The fossa is almost covered with the fascia. Some areas of the fossa are is not covered by the fascia because it is an extracapsular surgery and it is very difficult for us not to expose the muscle at all points. So inadvertently there will be some exposure of the muscles, but at the maximum area the muscle is covered with the fascia. So this will be a relatively bloodless and painless surgery. After the procedure, you can see the tonsillar fossa. There is no bleeding in the fossa, and the fascia is also present at the maximum area. Now, in the next video, we will perform the procedure on the left side. Thank you for watching.